Hi, everybody, and welcome to the EuroELSO 2021 Virtual Congress. My name is Jesse Wouters, and I'm Medtronic's Extracorporeal Therapies Training and Education Manager for Western Europe. During this session, organized by Medtronic, we'd like to take the opportunity to stay further connected with all our healthcare professionals by sharing interesting up-to-date knowledge, innovative product information, and clinical expertise directly from within the field. In this session, the experts, which I'm going to introduce to you in a moment, will focus on the impact of ECLS oxygenator technology on patient outcome. Let me introduce you now to our faculty. We have Professor Marco Ranucci from the Policlinico San Donato in Milan. Then we have Dr. Lorenzo Stefan Cesare Grazioli from the Papa Giovanni Hospital in Bergamo, also Italy. And last but not least, we have Mr. Mauro Cotza, also from the Policlinico San Donato in Milan, Italy. Very well, let's start with the first presentation. Dr. Grazioli will talk about clinical experience with the Nautilus ECMO oxygenator. And with that said, I'm very happy to pass the microphone over to you, Dr. Grazioli, so you can start with your presentation.
Thank you for inviting me. Thank you to Medtronic. I'm honored to speak at this symposium. Today, I will speak about the experience with the Nautilus new ECMO oxygenator from Medtronic. So, my institution, we are quite strict on the introduction of new equipment inside the clinical practice, and we do some stress tests on the new equipment we have got. Our stress test in this case, in the case of the oxygenator, which is a very sensible and delicate equipment, consists in a CT scan and angiography. Why we do that? So for CT scan, I show you. We examine essentially the oxygenator, okay, and we explore it inside, just to discover which are the components and the constituent we have got inside the oxygenator, because any other equipment for ECMO we can explore from outside. For instance, the head pump we can see from outside, but in the case of the oxygenator, we cannot. So we want to know the dimension and the geometrical characteristic of our oxygenator with the CT scan. We use that as a pre-case analysis because we want to know which are the starting point and the finishing point after the case. If there is something that can go wrong, we can analyze afterwards with a previous scan. And with knowing the geometrical and the technical feature of a new oxygenator, we can try to improve the life of the equipment and the outcome of the patient. In terms of fluid dynamic test, we use a kind of angiography. So what we do is manually inject some dye inside the blood compartment and see what happens. So this is a manual injection. Of course, the dye is flowing in a very, very smooth way inside the oxygenator. There is no turbulence in that. Why we do that? We want to know and we want to see how is the distribution of the blood inside the artificial lung, because it's crucial to understand which are the technical feature inside that can affect the performance during the extracorporeal assistance. And also we want to know which are the weak point of each oxygenator, if there is one, which can influence the resistance of that to the flow and the clot formation. As you can see, there is no problem at the moment. Then we pass through analyzing the distribution of the gas. So we inject some dye in the part of the gas sweep, and we can see we have got a peculiar distribution of the gas inside the artificial lung. In this case, we got one is going from the left to the right, and one from the top to the bottom. This is very good because the distribution of the blood and the distribution of the gas is important, has to be coupled to have a good outcome and a good performance of the oxygenator. Also, if there is at some point a clot which stops a part of the blood flow, in this case, we got a very good system that can allow a good gas flow inside the artificial lung. Then we're going to analyze the heating. So we do the same procedure with the dye inside the heating part of the artificial lung, just to see what is going on in the heater part. Why is it very important? Because if the heater is not very efficient and give you an heterogenic thermal distribution inside the lung, we can see that there are some points that are affected in terms of gas exchange and clot formation, because it changes the characteristic of the blood and the diffusibility of the oxygen and carbon dioxide. Then we can do some speculation and inference on what we have seen. So it is very low flow in injection. So imagine we are in a moment in which we want to do an ECMO weaning or a pediatric case which has got a very low weight type of patient, and we use a high volume oxygenator. We can see the distribution of the blood can decrease, okay? It can decrease in one side, the venous side, the inlet and the outlet. It is very important to know that, because this part is the stagnant part and can cause clotting. Okay, so the analysis of all the oxygenator take in account all these kind of features. Of course, these oxygenator give you the possibility to have a very linear, non-turbulent flow inside the fibers. So it limits a lot of this phenomenon of clotting during the long-lasting resistance. Of course, the clotting inside the fibers can affect the ventilation perfusion coupling and decrease the performance of the oxygenator. For this reason, we want to know and we want to assess this problem. Plus, the activation of the coagulation may lead to a coagulation problem for the patient, and may lead to a circuit exchange. This is a real life, the real life of in ECPR. We put on and stay on for 15 days. We can see the performance of the oxygenator are very good, and we can see the hydraulic resistance, which is in yellow, is quite good also after 15 days, and we have got a maximum of 18 during the assistance, so it's quite good numbers. And you can imagine these patients are usually affected by coagulopathy in the first part, so the stress on the circuit is very, very high. So what we do usually, we do also some CT scan afterwards. So this is very good to know and to examine your new tool you use in your clinical area, and you can see all the outlet part, which is at the right side of oxygenator in the all two images, are very, very clear. There is no clot in it. So in conclusion, we have used the new Medtronic oxygenator, the Nautilus, and we judge it feasible and safe for clinical use. Clinical performance are very adequate for long-lasting assistance. And these new technical features, for example, the GAX double site, are very useful for a long-lasting assistance, and is a new tool we can use as an alternative to a cylindrical oxygenator, which are a little bit tricky in terms of clotting. Thank you very much.
Thank you very much, Dr. Grazioli, for this great presentation. Let's go along with our second speaker of this session. Welcome, Mr. Mauro Cotza. Mr. Cotza will talk about how we can manage ECMO patients better and why. Also, Mr. Cotza will share his clinical experience with the use of the Nautilus Smart ECMO Oxygenator. Please, Mr. Cotza, the floor is all yours to start with your presentation.
So thank you for your kind invitation. I'm very pleased to be here and to share a few messages, few key points about our experience with the Nautilus in the smart setting. And I would like to start reminding that we have to keep in our mind that ECMO is a sort of, it's a support, a sort of dynamic time window that allow us and our clinician to deploy, to deliver medical therapies in order to heal patient and their underlying pathology. But it's undeniable that during ECMO, we face a burden of troubleshooting that are related to patient, but are also related to the ECMO support itself. And we can also say that in the last year, facing to the pandemic wave of COVID-19, we have seen a sort of amplification in some cases, and particularly in the veno-venous ECMO, about this presentation of troubleshooting. So the question is, if are we able to prevent, and in which way? How can we prevent? Issues are many, and we can find either in the veno-venous ECMO as in veno-arterial ECMO. And all of them require an intervention, an action by a clinician in order to modify the strategy and the outcome that we are going to face to. What is important when we have this sort of issues like ventilation, hypoxemia, hyperoxemia, or the mismatch between oxygen demand and oxygen supply. What is important is to minimize confounders, and this because allow us to identify better the real root causes of this troubleshooting. What we need is for sure a sort of numbers of safe and reliable indicators. So how can we detect timely? I take experience as an experience the COVID-19 because it's a fantastic scenario in order to show us all the possible events that can happen during an ECMO support, an ECMO course. And again, what we have to understand is if we are able to detect immediately this burden of issues that always happen in this kind of support, and which is the better way to manage everything happens. Algorithm has been proven to be fundamental, and but we have to keep in mind that for each algorithm, the decision-making points comes from clinical indicator. So again, we have to define and to try to identify in a proper way which are these indicators that allow us to advance in the treatment of the patient. What is important is also that many of these indicators are available, are clear and available, and so we have the possibility to give some solution to this question. So looking forward, this kind of indicator, it's the first step is what we experience either in another environment about the ECMO monitoring, but we have to do in the real world, in the real life. So to identify what we really need. And the indicator in this context has to be easy, has to be early, has to be effective, but what can I say is also that have to be continuous. We have to receive information in a continuous way. So we can define a couple of items that are probably summarizing all the aspects of ECMO. The first one is the oxygen demand supply matching, in which determinants are the pump flow and the arterial venous content and the metabolic rate. And the underlying indicators are oxygen saturation, content, hemoglobin content, partial pressure of O2, temperature. All of this combined with the patient, with the action of the patient, and particularly with the cardiac output and native lung residual function, give us a picture and an expression of what is the main aspect, for example, of a severe COVID patient. And this means that we have to face to a severe hypoxemic hypoxemic presentation as a normoxemic, or in another configuration, an hyperoxemic. We have also the second item that we have to match is that we should prevent preserve the hemostatic balance, because this may help us to preserve the organ from, particularly the brain, from any sort of ischemic or hemorrhagic burden. And on the other side, we also to preserve the membrane lung. The indicators comes from laboratory or point of care testing, imaging, and of course from transmembrane pressure, the gradient between inlet and outlet. What is important is that this allows us to understand if our ECMO is working properly, it's too much effective, is normally effective, or in the worst scenario, we have to replace the membrane lung. So again, what COVID rethought has is the pragmatic approach to the things. So we have to counteract, to have a balance between what is minimal and what is absolutely needful. And the question again is what we really need to know from our ECMO membrane lung. For sure, there are some indicators that give us a poor contribution, particularly in oxygen content. others that come from the normal blood gas analysis that we have from patient, and there are some other ones that are much more relevant, and particularly oxygen saturation, arterial and venous, the temperature that the temperature of blood leaving the oxygenator, that give us an some indication about how treat, for example, some special indication has a cardiac arrest or a septic shock. And the last indicator that we have for sure to keep in contact with is the delta pressure that allow us to early identify any sort of barrage inside the membrane lung. And it's obtained between a difference from the inlet and outlet that give us anyway some information about line and cannulas. We have two big concern about what the patient, what we have from the patient on the, or better, the interaction between the patient and the ECMO. One on the that are the same, two parts of the same coin, two faces of the same coin. The first one is hypoxemia. And what is important in this context is to have a real differential diagnosis for the refractory hypoxia, in order, as we said before, to define which is a confounder or what is a real root cause. So once we define that on an oxygenator or a patient is hypoxemic, is not dependent from the circulation of the oxygenator, the clinician can concentrate on other direction to improve the therapy. At the same time, oxygen can be harmful at the same time, because it's been that very high level of oxygen in particular contexts like cardiac arrest and severe cyanosis in a chronic or in acute way may be detrimental, with an increase in a 30-day mortality. And so to have some, if we are able to have some indicator that allow us to contain the level of oxygen coming from the oxygenator during this treatment can be useful. On this idea, we were very pleased to try again the Nautilus oxygenator from Medtronic MC3. We recently tested the normal version, and now we have the opportunity to test the smart version that has particularly features. What is important is that we obtain very good impression from the flow pathway, from the it's a smooth streamline and the extremely low transmembrane pressure with a linear P on F pressure on VO2 ratio, so that we have decided to dedicate as a mainly indication for COVID-19 patient. What the difference in the smart is that apart from these very good features in the fluidodynamic aspect, now we have also an online monitoring that is embedded within the screen of the oxygenator. The device assembly is particularly easy. This is, has been embedded in a ECMO pumped circuit donor because, as you know, the system is a standalone system. It has a touch screen with no cable, and this this aspect in the COVID-19 patient is particularly of benefit because reduce the contamination of hardware devices and make it easier the use in different patient and different context. Has a really easy to use in software interface, and has the possibility, even it's in a standalone fashion without any console that drive it, the possibility to some sort 30 minutes of autonomy coming from four AA batteries. The normal external supply, energy supply, come from a low voltage wall supply. The idea, as we said before, is to obtain and to evaluate an oxygenator that has some indicator, but not so many. And that is of particular interest because this allows us to have less sample in an hostile environment. And what impressed us was also that it's very reactive in any change in ventilation setting. The other aspect that impressed us very much was reliable calibration, even when we were obliged to stop the acquisition of data caused by transport for a CT scan over the 30 minutes. What is important is also that the ability of interpret the difference between saturation of inlet and saturation of the outlet part allow us to quantify it in a good way, a sort of recirculation phenomena in a very healthy way. And another aspect is that we allow us to calculate with a law of parsimony the membrane lung shunt, and so have some added information for the weaning from VV ECMO. Weaning from VV ECMO that happens with this protocol. It's our protocol. It's our standard protocol. It's composed by the VO2 trial off in a progressive declining of VO2 at the Christ. And once we obtain minimal support of VO2 according to normal saturation of the patient, we do the subsequent trial off on sweep gas that generally in 12 to 24 hours allow us to stop ECMO, but within a very tight patient control in order not to lose any important information. What we found was that, again, we had a very consistent trend between the VO2 of the membrane lung and the saturation that we find in the outlet port. And at the same time, as we already experienced in the standard oxygenator, there was a very linearly movement of saturation coupled with VO2. Obviously, this does not allow you to take any information because the data that we have are not enough to calculate pulmonary of the native lung. So we have to integrate with blood gas analytics coming from Van Gans and the transcutaneous saturation. And finally, we have to underline the added values of transmembrane pressure because as thrombosis is a major issue in COVID, this allows to live with a good awareness of the safety of the lung, and allow us also to understand, even in a remote context, if there is any kind of obstruction on the line or the cannula, particularly when we have to prone the patient or to transport for any deepening in imaging. As we can see in the video, it's very easy to set alarms, and again, even in the TN transmembrane patient, the calibration was very reliable. Even when the monitor switch off. So in conclusion, what we can say? We can say that ECMO course, as we know, it's present various decision-making points, and we can allow a better treatment if we are able to get some early data for a timely decision, clinical decision. What we found is that the nautilus non-invasive arteriovenous saturation data has been a good contributor to implement a safe ECMO weaning. And also the data coming from the transmembrane gradient has allowed, may allow, because we didn't experience it in the reality, any intra-devices thrombosis. So in conclusion, this aggregated data allows to effectively evaluate both the oxygenator performance and also which is the clinical contribution that this kind of, any kind of oxygenator, but this one in particular, can give to oxygenation. Thank you.
Thank you very much, Mr. Cotza, for this great presentation. Our third and final speaker of this Medtronic session is Professor Marco Ranucci. Professor Ranucci will give us a general overview of the advantages concerning flow path and coagulation impact in ECMO. So welcome again, Professor Ranucci. It's really an honor to have you here as a speaker, and please be my guest to start with your presentation.
First of all, I would like to thank the Medtronic team for this kind invitation at this very interesting symposium. And what I am expected to do is to provide a general overview of, well, more than the advantages, I would say the link between flow path and coagulation in ECMO and in any case, in any kind of extracorporeal circulation. And just for starting with some good old physiology, an important issue is blood viscosity and blood flow. Viscosity of a fluid is the ratio between the shear stress and the shear rate. And the unit of measure is centipoise. And of course, when the blood is in the liquid phase, the viscosity is about 3-4 centipoise. But once the coagulation starts, so the first fibrin strands are formed, then viscosity abruptly increases. And the blood changes the physical nature from a liquid fluid to a gel. So viscosity is defined based on the shear stress and the shear rate. And for a Newtonian fluid like plasma, the relationship is linear. But in case of blood, where we have the microparticles and we have erythrocytes, we have blood cells, then this gives course to a non-Newtonian fluid. That means that the relationship is not linear. And actually, this is a typical relationship between viscosity and shear rate that is defined per second for an hematocrit of 48. The basic determinants of viscosity, of course, are not just the shear rate, but even the temperature and the hematocrit of blood. In nature, the shear rate greatly varies within the circulation, depending on the site. And of course, we have places where the shear rate is in the range of 200, 250 per second. And these are the ascending aorta, descending aorta, and even the coronary circulation. And then in smaller vessels, the shear rate is considerably higher. Whenever we have any kind of change in the nature of flow, and the typical case is whenever within a conduit or within a vessel we have a stenosis, then something happens. That means that we have a flow acceleration, and this will give course to a number of factors. From the coagulation point of view, one of the things that will happen is that the von Willebrand factor becomes elongated and will give course to a number of changes. Basically, whenever we have an atherosclerotic plaque or a narrowing, then this unfolding of the von Willebrand factor and the exposed collagen or the foreign nature of the circuit in an oxygenator, then what we have is that the von Willebrand factor will get attached to the surface, and then this will give course to platelet activation, platelet adhesion, and finally platelet aggregation with a contribution of fibrinogen. And this is something that is typically occurring whenever we have a lesion at the endothelial surface, but this may happen as well even with contact with foreign surfaces. If we want to explore the relationship between the shear rate and the platelet and the coagulation as a whole, then there are different techniques. One of the most common is that you place the blood between a cone and a plate. This is called a cone and plate. And then the cone rotates, producing different levels of shear rate. And this is a device that we are developing at my institution. We are now close to the end of the process of development. So you see here, there is a cone, there is a plate. And what I will show you now is a very fast video accelerated to show you what we are able to do. Working in this range at around 240 per second as a shear rate, that is the most physiological one. And so this is a very fast video. You simply get some blood, you place it in a plate, and then this is viscosity, how viscosity is changing. Here you have 6 centipoise, so it's blood is in the liquid phase. But then all of a sudden, you will see that once coagulation starts, then viscosity abruptly increases. And here you will see this after about 3 minutes. You see how viscosity increases. Now we are at 40, 75, and then we can reach even values around 200 centipoise, and this is the case. You see how chaotic is this viscosity change in this phase, and we will see why this happens. And then after this chaotic activation phase, you will see that viscosity will go down and reach a steady, stable value. So what's the meaning of this? If you want to actually explore this relationship, that is exactly what you have seen with a smoothing technique, then we have the liquid phase of blood, and then we have the gel phase. This is increasing viscosity, this is the peak viscosity, and this is the steady viscosity. What's going on at these levels? We try to investigate this. We use very sophisticated techniques as microscopic electron microscopy. And by doing this, looking at the clot at this phase, at the peak viscosity, and at this phase as the steady viscosity, that this is what we found. This is a clot with a lot of activated platelets. You see all these pseudopods and this initial fibrin strand. This is quite a chaotic phase, and this is giving course to an increase in blood viscosity because this is a non-organized clot. But once you reach the steady state, then you will see this network of fibrin with the platelets that are organized within this network and some red cells inside. So platelets are reacting to the shear rate, and they are reacting in a shear rate dependent fashion, because you see these are free experiments, and by starting with a very high shear rate of 400, you see that the gel point is after 1 minute, but if we decrease the shear rate, then you will see that the gel point is moving to 2 minutes, 3 minutes, and so on. So the higher is the shear rate, the more the platelets becomes activated. This is the basic message. So by shifting this concept to what we are speaking of, so oxygenators and ECMO patients, within an oxygenator, you can have different ways for managing the path flow. So you can have a transverse design, an axial design, a radial design. This depends on the technology that the manufacturers are using. But the main goal is that we should minimize the areas of low flow and stasis. We should minimize surface area contact. I would say we should try to minimize the shear rate whenever this is possible, and to achieve a low blood side pressure drop. So in this picture, you see this new device, the new oxygenator with a very peculiar flow that is called the circular flow path. So this is how it works. You have an inlet, blood enters the guided inlet that is in the inferior part of the oxygenator, and then there is a very even flow within the oxygenator. And this lower blood inlet optimizes the orientation of blood prior to reaching the fibers. So this helps preventing an uneven blood flow. This is a comparison between two different oxygenators. A standard one, you see how the flow is, well, a little bit uneven. Here you see a very fast and even flow within this circular path oxygenator. You can see the same thing with this kind of picture and movie. And again, this is a standard oxygenator and how the blood is filling the fibers. And here you see in this circular path how different and more even is the flow of blood within the oxygenator. As a result of this, using this sophisticated technology, even the pressure drop seems to be better contained. This is an experiment with different kind of oxygenators, and this is a circular path oxygenator. You see, throughout 14 days of extracorporeal circulation, there is no increase in the pressure draw, whereas with other oxygenators, you can experience this at different stages and different times. Another thing is that, of course, we should not only optimize the shear rate and the uniform distribution of flow. We should even avoid to have areas of stagnation, of low flow, and we will see later on why. And so this is, again, an experiment. You see here the nautilus with a circular path, and here you see a competitor, and these blue and green areas indicates areas of potential low flow and stasis. At the end of the day, there are demonstrations that this different kind of flow is actually better received by the platelets, because in this 6 hours experiment, you see that the circular path oxygenator has a better platelet preservation than other kind of oxygenators. And this is real life. This is a case that actually Dr. Grazioli knows very well, because it's a patient that he sent me for ECMO 2 weeks ago or 3 weeks ago. So we put these young patients on ECMO due to a veno-venous ECMO due to a COVID-19 pneumonia. And we just used this new generation oxygenator. And so you see that the platelet count, of course, there was a decrease, a progressive decrease, with a stabilization after 4 days, and a very nice value around 175 cells per microliter. And actually, this patient did not receive any platelet transfusion during about 12 days of ECMO, and now is doing quite well. We have removed the ECMO about 4 or 5 days ago. So just to conclude, this shear-induced platelet dysfunction has very different mechanisms. There is platelet adhesion and aggregation, and this will result on one side with thrombocytopenia, on the other side with circuit thrombosis potential. Then there is a platelet receptor shedding, loss of receptors. So this is a potential cause for bleeding. There is even a platelet apoptosis with thrombocytopenia. There is, of course, a well-known acquired von Willebrand disease due to the elongation and denaturation of the von Willebrand factor with potential bleeding. And finally, the platelet-derived microparticles formation and even the plasma-free hemoglobin-mediated increase in platelet adhesion through an increased activity of von Willebrand factors. And both these effects are potential determinant of thrombotic complications. And there's a nice study that was published a couple of years ago. This is ECMO is a simulation of pediatric ECMO, and the authors actually used two different circuits. One was pump and oxygenator, the other one just pump, and they measured an incredible amount of things, actually demonstrating that platelet activation is time dependent and is independent from the presence of the oxygenator. So we have an increased platelet activation. We have an progressively increased microparticle formation. And we have the shedding of receptors, because you see expression of GP1B and expression of GP6 are decreased in a time-dependent fashion. Finally, the platelet adhesion to the von Willebrand factor is progressively decreased. The same for collagen, but the most important one, that is platelet adhesion on fibrinogen. And fibrinogen is the basic protein that is stratified on the circuit of the oxygenator, on the ECMO circuit. And so this is progressively increased. And this is more evident when you are working with the oxygenators than with just the pump. So to conclude, there is actually a double hit of shear stress in ECMO patients. On one side, within the circuit, there are for sure high shear stress areas that will determine invariably a platelet activation. On the other side, there are areas of low shear stress, areas of stagnation, and here you have the possibility of platelet aggregation. So it may happen that at point A, you have activation, but at point B, you have the real aggregation and thrombus formation. So I think that every effort to optimize the flow inside the circuit, and especially the oxygenator, is worthwhile to decrease the possibility of, on one side, bleeding, on the other side, thrombotic complications on ECMO. Thank you very much for your attention.
Thank you very much, Professor Ranucci, for this great presentation. This brings us already to the end of this Medtronic symposium. I'd like to thank the faculty once again. So thank you very much, Professor Ranucci, Dr. Grazioli, and Mr. Cotza for participating in this session. We also hope that everybody enjoyed our symposium, and more importantly, we hope you enjoyed all the presentations. Thank you, and I'm looking already forward to seeing you participate in Medtronic's future sessions. Bye, everybody, and have a lovely rest of the day.